This is the fifth in a series of presentations on the topic of disorders predominantly affecting the diaphysis, metaphysis, and physis in veterinary patients. In this presentation, we're going to describe the effect of malignant neoplasia on the bone that you may encounter during radiography of dogs and cats. By the end of the presentation, you should be able to identify and describe the radiographic appearance of malignant primary osseous tumors, osseous metastatic neoplasia, and osseous involvement secondary to soft tissue malignancies. Additionally, given the radiographic appearance, you should be able to provide a ranked ordered list of differential diagnoses. Let's start with a review from our presentation on osseous alterations, and let's reconsider how to tell non-aggressive versus aggressive lesions of bone. If you recall, generally considered non-aggressive findings include geographic patterns of lysis, no lysis of the cortex, a solid periosteal reaction, and a distinct or short transition zone. Whereas generally considered aggressive findings in bone include the moth-eaten or permeative patterns of lysis, the presence of lysis of the cortex, the spiculated or amorphous periosteal reactions, and an indistinct or long transition zone. Remember that we could also look at rate of change of lesion over time, but that would mean that we need to have more than one set of radiographs. If you recall, most lesions will have a mixed pattern of lysis and periosteal reactions, and we need to classify the aggressiveness of the entirety of the lesion based upon the most aggressive finding or findings. So for example, a lesion with a distinct or short transition zone, a solid periosteal reaction, and permeative lysis should be classified as an aggressive lesion. So the distinct or short transition zone is a non-aggressive finding. The solid periosteal reaction is a non-aggressive finding, but the permeative lysis is definitely an aggressive finding. So the entirety of the lesion will be an aggressive lesion. So if we consider how malignant neoplasia may affect bone, we can have malignant primary bone tumors, and this is an example of a malignant primary bone tumor affecting the proximal humerus. We can have metastatic or multicentric bone tumors, and this is an example of a metastatic tumor to this proximal ulna. Or we can have a soft tissue tumor that secondarily affects the osseous structure. And in this example, there's a soft tissue mass caudal to the femur that is causing some lysis of the femur, so that has primary bone involvement. Now, admittedly, in this presentation, we're only going to focus on malignant processes in the bone, and there are certainly benign primary bone tumors, but in the essence of time, we're not going to discuss that. However, when you evaluate your radiographs, you will use what you learn to decide if something is a non-aggressive or an aggressive lesion. Now, a metastatic lesion, by definition, would be from a malignant process. And there are some, benign soft tissue lesions that could potentially affect bone, but we will focus on the malignant lesions. So let's start with the malignant primary osseous neoplasia. The malignant primary bone tumors include osteosarcoma, of which 85% of primary bone tumors will be osteosarcoma, chondrosarcoma, which makes up about 5 to 10% of the primary bone tumors, and then fibrosarcoma and hemangiosarcoma, which can be a primary tumor of the bone. Each of those make up less than 5% of all of the primary bone tumors. Malignant primary bone tumors should be monostatic, so only affect one bone, and typically they affect the metaphysis of the long bones, although they can also affect the flat bones of the skull, the vertebrae, and the ribs. In most patients with primary bone tumor, you'll find that they are middle-aged to older. However, osteosarcoma has a bimodal distribution, and that has a small peak of bone tumors in patients between 18 to 24 months of age. Large and giant breed dogs are most commonly affected, and cats are definitely less commonly affected. In cats, osteosarcoma is also the most common primary bone tumor, but the prevalence is much lower than in dogs. In cats, the mean age is about 10 years, and it does not have a bimodal distribution. Interestingly, in cats, the hind limbs are affected more than the front limbs. 75% of the osteosarcoma affecting bone will affect the appendicular skeleton, and it affects it in fairly common sites. Those sites are listed here. So the distal radius and the proximal humerus are quite common, and we can remember away from the elbow. And in fact, the distal radius is probably the most common site. Some people have postulated that maybe this is because that is the most weight-bearing site. And then other common sites include the distal femur and proximal tibia, or we can remember toward the stifle. And then the distal tibia is also a common site. As we've kind of reminded ourselves about what an aggressive lesion looks like, that will help us when we think about radiographic findings. So definitely, this is an aggressive lesion. And they have variable amounts of lysis and proliferation, but the pattern of lysis is typically aggressive and oftentimes involves the cortex. And the pattern of periosteal reaction is also generally aggressive. As I said earlier, a primary bone tumor should affect only one bone, so it should be monostatic. And this is a thing that can help us when we're talking about other aggressive lesions, such as from fungal osteomyelitis, like we've seen recently in another presentation, where that is more often than not polyostotic. So if you have more than one bone involved, primary bone tumor should not be our differential diagnosis. And then it is not uncommon for us to have soft tissue swelling associated with these primary bone tumors. And in fact, some of the bone tumors have a large soft tissue component, not just from swelling, but from a tumor component. Now, the radiographic findings are obviously nonspecific. So aggressive bony lesions can be caused by other things. And the other thing to keep in mind is we cannot reliably determine the type of primary bone tumor from the radiographic appearance. Here's an example of a primary bone tumor in the distal radius of an older dog. Lateral view, we can see that there is moth-eaten lysis. It is centered at the metaphysis, but it is also in the distal diaphysis and the epiphysis. And then associated with that moth-eaten lysis, there is actually lysis of the cortex. I can see that the lysis is more severe at the medial aspect, and that is where the predominant cortical lysis is also at. And then this patient has, to a lesser degree, some periosteal reaction, and this is somewhat amorphous because it doesn't really have a good shape at the cranial aspect, although it is more irregular and more partially continuous at the medial aspect. The lysis actually goes down into the joint, it looks like, and then there is associated soft tissue swelling. And as I said, the distal radius is a very common site for the osteosarcoma. Here's another example of osteosarcoma in the distal radius of another older dog. This one you can see is more proliferative than the other one. However, there is still kind of this area of moth-eaten lysis that's in the distal diaphysis, the metaphysis, and a little bit into the epiphysis. Notice that there is some irregular and even spiculated periosteal reaction that is surrounding this lesion. It's a little bit more palisading or semi-aggressive on the medial aspect here. And then notice I forgot to point out on the other one that this is an indistinct or long zone of transition. So remember that indistinct zone of transition means that we have gradually, so going from normal, it'll gradually get worse and worse. So it's not kind of distinct between normal and abnormal. So this lesion here has a lot of signs of aggressiveness in all four of the things that we could assess. This slide just shows some additional examples of how osteosarcoma might look in different patients. This first image on the left of the slide is actually a juvenile onset osteosarcoma. So this dog is 18 months old. In the distal femur here, we have some moth-eaten lysis in the metaphysis, a poor zone of transition, and then more proximal to the area of lysis, there is some solid and irregular and palisading periosteal reaction. Notice there is cortical lysis here as well. In the middle of the slide is a predominantly lytic osteosarcoma that's in the distal radius of a middle-aged dog. So almost looks like a geographic area of lysis, but we can also see some moth-eaten and permeative lysis, as well as a little bit of cortical lysis, and only a non-aggressive solid periosteal reaction. So the thing you don't want to confuse this with is that there's a region of geographic and solid lysis only, or solid periosteal reaction only, and that this would be benign because there is additional aggressiveness with indistinct transition and permeative lysis. And then this osteosarcoma of this proximal humerus on the right in an old dog is also kind of a mixed proliferative, but predominantly proliferative lesion with moth-eaten lysis, cortical lysis, but then this very amorphous and even somewhat spiculated periosteal reaction with a large amount of associated soft tissue swelling. Here's an example of a chondrosarcoma in the tibia of a middle-aged dog. So if you notice, this proximal tibia has a combination of moth-eaten lysis, even down here with a long transition zone, as well as kind of more, almost popcorn-like periosteal reaction. It is not uncommon for chondrosarcomas to be fairly proliferative and kind of have this nodular periosteal reaction. But again, we can't use any radiographic appearance reliably to distinguish the different types of primary bone tumor. So typically in my differential or conclusion, I'll say the findings are most consistent with a primary bone tumor, and then I might even modify it and say of which osteosarcoma is most common. Here's an example of a primary hemangiosarcoma of bone in the proximal humerus of an older dog. And if you notice, this one is predominantly lytic. We can see moth-eaten lysis. We can see cortical lysis. The lysis is at the metaphysis, in the diaphysis, and up into the epiphysis as well, the head here of the humerus. There is a little bit of periosteal reaction here along the caudal cortex, kind of showing some expansion of that tumor outside of the bone. And I don't know that I see a whole lot of soft tissue swelling, but it is more challenging to identify radiographically swelling of the proximal limb. So next, let's look at metastatic lesions to bone. And metastasis to bone can occur with any tumor type. But the primary tumor commonly originates in the prostate, the bladder, the urethra, and mammary tissue. The epithelial tumor types are much more common to met to bone than the mesenchymal tumor types, so carcinomas of the sites that I listed here, but also squamous cell can met as well. Common sites of metastasis include the axial skeleton and the proximal extent of long bones in the appendicular skeleton. So in the axial skeleton, the vertebrae and ribs are common sites of metastasis. And then in the appendicular skeleton, the femur and humerus are common sites proximally for metastasis. So if an osseous lesion is identified in a patient with a known tumor, your primary differential should be that it would be a metastatic lesion. However, we haven't always identified the primary tumor when the patient actually presents for the osseous lesion, so it's always important to do a careful physical examination when you're assessing your patients to identify if there is another primary. Unfortunately, the radiographic findings of metastatic osseous neoplasia are, again, nonspecific and really will oftentimes look like the same findings that we talked about with primary bone tumor. The one thing that might help us out is that because they are hematogenously spread from the primary tumor, oftentimes more than one bone is affected. So if you see polyostotic lesions, metastasis can be on our differential list. However, if we see polyostotic lesions, we should take primary bone tumor off from our differential list. The metastatic lesions are oftentimes metaphyseal location due to hematogenous spread in that rich capillary network, but they like to be in the diaphysis as well, potentially near the nutrient foramen, again, because of the blood work, the blood network and where it will spread. And then for metastasis, the osseous findings are usually a semi-aggressive to aggressive lesion. Again, just like we talked about with primary bone tumors, variable amounts of lysis and proliferation. Our pattern of lysis is still typically aggressive. The pattern of periosteal reaction may be semi-aggressive, but also typically aggressive. This slide has a couple examples of metastatic osseous neoplasia. On the left side of the slide, there is a aggressive appearing lesion in the proximal humerus in a patient that has metastatic mammary carcinoma. So there is moth-eaten lysis in this proximal metaphysis of the humerus. Some of it extends a little bit into the tubercle over here. There's a little bit of solid periosteal reaction, and then this lesion has an indistinct transition zone, so an aggressive appearing lesion. The patient to the right of the slide has pretty aggressive metastasis to both the radius and the ulna from a splenic hemangiosarcoma. So then the primary tumor is the splenic hemangiosarcoma, and this is different from our discussion of primary bone tumor from hemangiosarcoma. So if we notice on this patient, most severely affected is the olecranon here, where there is a severe amount of moth-eaten lysis, lots of cortical lysis. But if we look in the diaphysis of the radius and the ulna, there is permeative lysis, and some of this lysis also affects the cortices. Here's an example of a patient that has polyostotic lesions that are metastatic from a primary tonsillar squamous cell carcinoma. So initially on thoracic radiographs, there are 2 lesions of the left ribs that are identified. These are more proliferative, but there's also lysis of the rib as well, where the proliferation is. And then this patient also had painful stifles, and when they took radiographs of the stifles, what was evident is not actually stifle disease, but areas of lysis, kind of subtle here, and some sclerosis in the distal femur on the right, and then more moth-eaten lysis and sclerosis in the distal femur on the left. And both of these were sampled and came back metastatic squamous cell carcinoma. Here's another patient that has a lesion that is aggressive in the distal radius. If we look here, there is very aggressive moth-eaten lysis with cortical lysis. It's expanding the bone. There's a little bit of kind of palisading periosteal reaction. We can see the cortical lysis here medially as well, and a little bit more irregular and palisading periosteal reaction. Some associated soft tissue swelling. Notice that the ulna here is not involved. These little areas of lucency are the normal trabeculation, so this is a monostotic lesion. However, this patient had an anal sac adenocarcinoma, so this is a presumed metastatic lesion. However, it's also the area that a primary bone tumor would like to start. So I think an additional differential in this patient has to be a malignant primary bone tumor as a second tumor in this particular dog, because our patients oftentimes have more than one tumor at the same time or at different times in their life. Now, here's a patient, this is an older Labrador, who has more of what I'll call a multicentric tumor that's affecting the bone. So this dog has T-cell lymphoma, and he was very painful in his hind limbs, and so several different radiographs were obtained. And if you notice, there are several lesions affecting this dog's pelvic limbs. So let's start with the middle of the slide here. And if we look on the pelvic bones, there are regions of moth-eaten lysis in the ilium, the pubic bone, and the ischium. But this patient also has moth-eaten lysis here in the proximal right tibia, as well as moth-eaten lysis in the tibial crest on the left and the distal tibial metaphysis, and then a little bit in the distal left femur. So this is multifocal, so polyostotic lesions that are predominantly lytic that are proven to be lymphoma that is more of a multicentric neoplasm. Then finally, malignant soft tissue neoplasia can affect adjacent bone, either through actual direct invasion of the tumor, but also sometimes due to pressure necrosis, where the soft tissue mass is just exhibiting pressure on the bone and the bone kind of remodels or necroses around it. Radiographic findings include a soft tissue mass that is adjacent to the bone. And then when you look at the bone adjacent to that mass, there may be more than one bones that are actually involved, but they're going to be regionally involved, and it can affect any part of the bone. So even though we're talking about diaphysis, metaphysis, and physis, certainly it could affect the epiphysis or the joint. And then the radiographic changes may be non-aggressive, semi-aggressive, or aggressive, and have variable amounts of lysis and proliferation. Now, one way that this might look different from our metastatic and primary bone tumors is that the radiographic changes to the bone are often kind of peripheral or eccentric, whereas our primary bone tumors and the metastatic bone tumors more often look like they are originating in the center of the bone and may actually expand the bone outward. Here's an example of a cat that has a soft tissue sarcoma of the kind of tarsus and metatarsus, and we can see all of this irregular mass-like soft tissue swelling of the tarsus and the metatarsus. And then when we look, because oftentimes we might know this is a soft tissue tumor, but then we take the radiographs to see how extensive it is and maybe how much of the bone it affects. So when we look closely, we can see that there is kind of this moth-eaten lysis affecting the calcaneus here. We can see a little bit of the talus being affected as well. So two different bones, but regionally affected by this soft tissue mass. Here's an example of a soft tissue sarcoma in a similar location in a dog that's also affecting the bones regionally. So this soft tissue mass-like change is kind of more extensive than just the really big opaque area, because that also affects kind of the area of the common calcaneal tendon. And it's mainly along the plantar and the kind of lateral aspect of the tarsus and metatarsus. When we look closely, this is the fourth tarsal bone, and there are some regions of lysis that are probably from extension from this soft tissue sarcoma. Here's an example of a nail bed tumor, specifically a nail bed melanoma in a dog that's causing some regional bone changes. So the mass-like swelling here is of the third digit, and at the level of this swelling, we can see on both of our views, this is the distal phalanx. The distal phalanx is quite lytic. Compare it to the distal phalanx of the other digits. So the ungual process and the ungual crest, and even the body of it, has quite a bit of lysis. And then on the middle phalanx, there is some fairly solid but irregular periosteal reaction, and then even a little bit of lysis down at the distal end. So nail bed melanoma is one of the digital tumors. The squamous cell carcinoma is probably the most common nail bed tumor. One thing, however, we need to keep in mind is that we cannot distinguish or differentiate between a neoplastic lesion of the digit or an infectious or inflammatory lesion. So digital infection in the dog could look like this, or a foreign body with a granulomatous inflammatory lesion. So we certainly have to biopsy a lot of these lesions to come to a definitive diagnosis. Here's an example of a dog that has a periarticular histiocytic sarcoma, and this is affecting multiple bones. So the soft tissue mass is a little bit harder to see, but there is this kind of focal soft tissue swelling cranial to the radius, but also more medial to the elbow and even a little bit more lateral to the proximal radius here. So quite a bit of kind of soft tissue mass-like swelling, although not quite as distinct as some of the other masses we looked at. When we look at the regional bones, especially on the ulna here, I can see at the caudal cortex a spiculated periosteal reaction. And then on the kind of anconeal process and this cranial part of the olecranon tuberosity, there is geographic lysis. And then on the cranial caudal view, we can see another focus of geographic lysis in the lateral aspect of the humerus. So two bones being involved by this soft tissue histiocytic sarcoma. Be sure to consult the textbook chapter listed here to further see an explanation of these different types of tumors affecting the bone, as well as to be able to look at additional examples.